First of all, welcome to the third of our collaboration in surgery presentation evenings, and welcome to all the speakers and to the judges. I'm Matthew Hatfield. I'm the chair of the Victorian State Committee, and the other three judges, Patrick Lowe, Amy Tozel and Marilyn Raj. First of all, the Royal Australasian College of Surgeons acknowledges the traditional owners of country throughout Australia and recognises their continuing connection to land, waters and community. We pay our respects to them and their cultures and to elders both past and present. We've gone through most of the questions, so we'll make a start and go straight into the presentations. The next presenter on my list is Anne. Anne, are you ready? Are you there?
Yeah, I'll just share the screen.
Will you share the screen? I'll tell you if I can see it.
All right.
Just see a big A at the moment.
Here we go.
Yep, that's coming up.
Okay.
Okay, that's great. Off you go whenever you're ready.
Good evening, everyone. So today I'll be presenting my findings from my systematic review on machine learning for predicting major molecular markers in glioma on MRI. So glioma is the most common form of primary brain tumour, and over the past few years, molecular information has become increasingly significant for classifying, prognosing and predicting treatment response in glioma patients. So currently this is done by histopathology, but there are several limitations with that, including heterogeneity within the tumour. So with MRI being the most common form of imaging modality we use to assess brain tumours, it has abundant information reflecting tumour physiology and microenvironment at a very fine voxel level. And this information can be quantified. So with the advances in machine learning particularly, we've become interested in the concept of radiogenomics, which is the process of extracting these imaging features to predict underlying genotype of the brain tumours. So as shown in this diagram, these features can range from tumour texture, tumour intensity, shape, as well as a wide range of statistical properties. So an optimised machine learning model has many implications as depicted here, such as predicting survival, etc. So my primary objective was to evaluate the diagnostic accuracy of machine learning models in predicting molecular markers in glioma. We were also interested in any factors that could affect the performance of these machine learning models. And listed below here are the genes we were interested in, one of which, called IDH, is a commonly assessed mutation in glioma and done routinely as part of pathology. So our study was conducted in line with the PRISMA statement, and we applied a set of inclusion and exclusion criteria. We ran the primary search in several databases as listed there, and together with my team member, we independently screened the titles and abstracts followed by full text review. We then assessed the risk of bias in each study using a well-established tool called Quartus2. And finally, I conducted statistical analysis using 2x2 table values extracted from each study. And I used a bivariate model to determine the pooled sensitivity and specificity across the studies. And we also assessed heterogeneity using subgroup analysis and meta-regression. So here are the results of, as shown on the right, the flowchart depicting our search process. So we found 44 studies which met all eligibility criteria. The sample sizes were variable, and less than half of studies used advanced MRI sequences compared to conventional sequences. The common machine learning algorithms did vary, but mostly it was using random forest or support vector machines. And of note, 7 out of the 44 studies used deep learning techniques, which is a subset of machine learning techniques. Interestingly, only 10 out of the 44 studies externally validated their findings in a separate cohort of patients. Here are the results of our risk of bias assessment. So as shown in the diagram, most of the studies scored low risk in the reference standard domain, but a large proportion of studies had unclear risk of bias in other domains due to poor reporting. In terms of the applicability on the right, there were no major concerns except 7 studies which had less generalizable patient population. We found that through our meta-analysis that IDH mutation could be predicted with a sensitivity of 88% and specificity of 86% in training dataset. And this was replicated in validation dataset as well. So as shown on the left, the SROC curve, there was significant heterogeneity within the specificity, which is represented by the false positive rate on the x-axis, and is also depicted in the forest plot on the right. So we found that in part this heterogeneity was associated with use of data augmentation during the training process, as well as the choice of advanced MRI sequences as opposed to conventional sequences. And finally, here I also have the table showing our results for other genes that that the machine learning models predicted. And of note, 2 of the genes, such as the 1p19q co-deletion and MGMT methylation, showed very promising results in the training set, but this need to be further validated. So through my systematic review, it became clear that there are several important considerations for applying these models clinically. So this includes appropriately selecting your patient population, considering methodological factors like use of data augmentation, as well as external validation of the findings. So future studies, in terms of that, it is important to investigate the underlying biological mechanisms of those MRI features, as well as importantly investigate feasibility in routine clinical workflow. And here listed are some of the limitations we recognize in our systematic review. So in conclusion, machine learning models demonstrated moderate to high accuracy in predicting IDH mutation in glioma on preoperative MRI. We also found that there were promising results for predicting 2 other genes, but this needs to be further validated. So in short, optimized machine learning models has clear clinical value because it could provide a non-invasive and objective tool to detect molecular information, which is significant for predicting survival and treatment response in glioma patients. And I think it's worth emphasizing that for future work in this domain, it is crucial to involve neurosurgeons, neuroradiologists, pathologists, and computer scientists. Thank you.
Thank you very much for that presentation. That was very interesting. Patrick, have you got any questions since it's your field?
I'm very interested. I'm very interested because in theory, using the machine learning, you'll stop me from working, Anne. That's it. So how do you think that this machine learning model will help me as a neurosurgeon into the future then?
Yeah, so starting from the bigger picture, so the use of machine learning models has many applications both preoperatively and postoperatively. So preoperatively, for example, in distinguishing between different tumor types, so glioblastoma versus lymphoma, for example. Also, well, my systematic review is looking at genotyping, so that has associated significance for planning potential surgery because at least one of the paper I read showed that maximal extent of resection in IDH, I think IDH, so based on the IDH status of the glioblastoma, maximal extent of resection showed greater benefit depending on the genotype. So it has potential implications from that angle. But I think more interestingly, there are also studies looking at post-operative use to distinguish between recurrence of tumor versus radionecrosis. So my thinking is, for example, using MGMT methylation, which is commonly what we can predict a response to chemoradiotherapy in glioblastoma, that can perhaps be integrated in predicting whether it's radionecrosis or recurrence of glioblastoma. Yeah.
So one of the issues with a lot of machine learning models, and it's quite a expanding field at the moment, is whilst they're great in the research field, their translation into day-to-day clinical use takes some time sometimes in putting those models together so that they can be used quickly and easily. What sort of stage is the machine learning at in this particular field? How user-friendly is it?
It's a really good question, and we definitely don't see it widely, well, really adopted in clinical use. And a lot of people think it could be due to the complexity of the process, but in fact, with well-established tasks, such as distinguishing IDH mutations specifically, the process involves segmenting the tumor, and this is done actually in radiosurgery or radiotherapy anyway, so the softwares are widely available. And also the process of extracting features from MRI can be done using open source softwares. So there have been a few studies looking at implementing it in the radiology workflow, and they have found it feasible in terms of time and cost. I think it's really dependent on the tasks. For some of the other mutations, for example, the evidence is not as strong, so that will obviously need further validation before clinical application. Yeah.
Okay, thank you. Any further questions? If not, then thank you very much for your presentation.
Thanks.
And we will move along. So the next presenter on my list is Yong Yao Tan. Are you there?
Yep. I'll start sharing my screen.
Okay. Okay, I can see that. So whenever you're ready, you can make a start.
All right. Good evening, ladies and gentlemen. My name is Yong Yao Tan, and I am a final year medical student at Monash University. I would like to thank the Royal Australasian College of Surgeons for the opportunity to present, and my fellow co-authors and supervisors for their help with this project. Today, I'll be presenting a systematic review and meta-analysis outlining the complication rates and functional outcomes of tibial talar calcaneal nailing when used as a primary treatment for ankle fractures. I have no conflicts of interest to declare. So ankle fractures are common injuries, and with an aging population, the incidence is likely to increase. Unstable ankle fractures can be managed operatively or non-operatively. However, open reduction and internal fixation is associated with higher rates of infection or wound breakdown compared to non-operative management. However, when managed non-operatively, patients have a higher rate of radiologic malunion compared to operative treatment. Therefore, unstable ankle fractures may not be suitable for non-operative management. Ideally, the treatment of an ankle fracture would allow early full weight bearing to restore independence to pre-injury state and minimize post-operative complications. In selected patient groups, TTC nailing may be a viable alternative. The TTC nail is less invasive and may be associated with less soft tissue complications. Furthermore, TTC nailing may have greater mechanical stability than extramedullary fixation and therefore is more suitable for early weight bearing. Therefore, this systematic review aims to outline the complication rates and functional outcomes after TTC nailing for the primary treatment of ankle fractures. This slide outlines the method. So in total, 3,337 studies were identified from the initial search, and after sieving out duplicates and irrelevant studies, a total of 10 studies were included. Of the 10 studies, 9 were case series, while 1 was an RCT. There were a total of 252 ankle fractures. The mean age of patients was 75.5 years. Majority of patients were also females, and the mean follow-up was 79 weeks. Going on to the complications, the prevalence of surgical site infection was 11.2%. However, when only including patients with closed fractures, the prevalence of surgical site infection was 2.8%. There were no documented cases of wound dehiscence. Implant failure occurred in 8.1% of patients. Unplanned return to theatre occurred in 10.1% of patients. Malunion or non-union was reported in 8.4% of patients. And the overall all-cause mortality at the end of follow-up was 26.6%. A subgroup analysis for the complications for patients age over 60 was performed for patients age over 60 with closed fractures to facilitate comparison with the Ankary injury management trial, which compared ORIF with close contact casting in elderly patients with unstable ankle fractures. Due to a lack of information, only selected complication profiles could be analyzed. The prevalence of superficial surgical site infection and malunion or non-union were both 3.2%. There were no cases of deep surgical site infection, and all-cause mortality at final follow-up was 20.8%. Going on to the functional outcomes, The Olerud-Molander anchor score is a 100-point patient-reported outcome measures and was reported by 4 studies. The pre-injury and post-operative OMAS from these 4 studies had a mean reduction of 7.9 points, and the mean post-operative OMAS score was 54.3. Going on to mobility aids, there were 6 studies that reported patients' pre-injury and post-operative type of mobility aids. 81.5% of patients were able to return to use their pre-injury mobility aid. Among patients who were able to ambulate independently or only required a walking stick pre-injury, 23% required a walking frame or wheelchair post-operatively. Going on to my discussion. So the minimally invasive nature of TTC nailing has led to no reported cases of wound dehiscence, which is a recognized risk factor for increase in patient morbidity. Among patients with closed fractures, the rates of surgical site infection was on the lower end of the spectrum when compared to closed fractures treated with ORIF. There were also no cases of deep surgical site infection among this group of patients. Minimizing deep infection is important as it is a known cause of significant morbidity and mortality in the elderly. Therefore, TTC nailing may be preferable to ORIF for patients at high risk of wound complications. The reduction in OMAS after TTC nailing had minimal clinical significant difference. The MCID has been reported to start after a reduction in 10 points or more on the OMAS. The patients selected for TTC nailing had a lower OMAS of 62.2. This indicates that pre-injury functional status is an important consideration for surgeons when considering TTC nailing.
Minute.
These were our limitations. And in conclusion, TTC nailing is an alternative technique to ORIF for patients with a low initial functional demand, with unstable fractures requiring operative management, but also have an increased risk of complications after ORIF. Although the mortality rate is high among this group due to patient fragility, most can expect to return to using pre-injury walking aids after TTC nailing. Further comparative studies can better identify patient populations that would benefit most from this procedure. Thank you.
Okay, thank you very much. We've got questions. Amy, I'm sure.
So Yong, just 2 points. Thank you for your presentation. I was involved in one of the papers when I was on my fellowship in Bristol, but one of those, and we did compare them to total contact casting. Yeah. So you mentioned that a hindfoot nail might be an alternative to an open reduction internal fixation for open fractures. What about compared to non-operative management with close contact casting?
So in our systematic review, we included both open and closed fractures. The subgroup analysis with closed fractures for patients above 60 was to compare with the Ankle Injury Management Trial. In terms of comparison of a hindfoot nail to total contact casting, I think that more studies have to be done in order to facilitate a comparison between the two methods. But with hindfoot nail, I think they would allow for greater stability compared to total contact casting.
Okay. If you present it anywhere else, there's a big trial going on at the UK at the moment, big multi-centre randomised control trial looking at this. And I think if you're going to present meta-analysis comparing open reduction internal fixation to TCCs, open reduction internal fixation to hindfoot nail, you've got to include the option of total contact casting for these patients.
Okay.
Your other comment was if you exclude patients that had open fractures, the infection rates were much lower compared to open reduction internal fixation. Did you exclude open fractures for patients that had open reduction internal fixation in your analysis as well?
Yeah. So for our analysis, for patients that we excluded open fractures, it was on the lower end of the spectrum when compared to ORIF for closed fractures only. It wasn't necessarily lower, but it was on the lower end of the spectrum because with ORIF, our literature review showed something like 2.8% upwards towards 10%. And it wasn't lower than that, but it was on the lower end of the spectrum.
Okay, thank you very much for that, and thanks for your presentation. I enjoyed that.
Thank you.
Okay. The next presenter on my list is James Steeves. Are you there and are you ready?
Yep, that's me. Let me just get the screen share up.
Okay.
It's
getting there.
Can everyone see that?
Yep, whenever you're ready.
Okay. So my name's James. I'm a final year medical student, and I'm going to be talking about postoperative delirium and specifically how sleep-regulated neuroinflammation relates to its pathophysiology. So to start off with, I don't have any disclosures or competing interests to declare, but I'd like to acknowledge my supervisor this year, Dr. Prabhat Lamachani, and also like to acknowledge the Royal Australian College of Surgeons for hosting this tonight. So postoperative delirium can be defined as disordered thinking, altered consciousness, and impaired cognition that occurs within 7 days postoperatively. It's a common health issue, and anyone who undergoes surgery, including general anesthesia, is at risk of this condition. In the future, with an aging population and more medical procedures being performed, it's going to have a significant impact on the public health system. There are certain risk factors that I've listed here, but our understanding of its etiology is quite poor. Currently, our preventative and treatment strategies include medication optimization and monitoring the depth of anesthesia, but the incidence of postoperative delirium still remains quite high despite this. One modifiable risk factor that we can implement in hospitals is sleep, as sleep disturbance is associated with postoperative delirium and is something I'm going to discuss today. The methodology that I've used in this project is a narrative review. So I've searched several databases for information on these 3 different topics. And the reason why I chose this methodology was because although research into any 2 of these topics and their associations is quite high and detailed, research looking at all 3 concurrently is pretty limited. So I chose this methodology. So to start off with, surgery is associated with an increase in systemic inflammation, and it leads to postoperative delirium through several ways. Increased increased levels of systemic inflammatory markers are associated with postoperative delirium, and the greater the level of inflammatory markers, the higher risk of development of postoperative delirium. Systemic inflammation is then translated to the brain through causing endothelial dysfunction and increased blood-brain barrier permeability. And finally, neuroinflammation is thought to cause postoperative delirium through its effects on microglia, which are the macrophages of the brain, and through increasing synaptic dysfunction and the direct apoptosis of neurons. Ultimately, this causes the cognitive effects observed in postoperative delirium. Now, sleep in healthy individuals is a key regulator of neuroinflammation, and it's also key for other processes like immune system modulation and memory consolidation. Sleep is a dynamic process though, and it involves the brain transitioning through different electrical phases of activity, including REM sleep and non-REM sleep. Each stage has specific functions that I'm not going to discuss here in the interest of time, but they are important regulators of inflammation in their own way. And some of the things that they have been shown to do is regulate microglia, like I've spoken about previously, and through the glymphatic system, which serves to clear the brain of toxic proteins like amyloid beta. So if someone has disturbed sleep, the results show that they have higher levels of neuroinflammation in the brain. And another factor is that sleep and neuroinflammation exist in homeostasis. So much like sleep clears inflammation from the brain, high levels of neuroinflammation is actually going to increase sleep drive. If postoperative neuroinflammation is key to the etiology of postoperative delirium, as I started talking about, and sleep is a key regulator of neuroinflammation, then we would expect to see that impaired postoperative sleep is associated with increased risk of postoperative delirium. And this is indeed the case. This systematic review here showed that there's a significant association between impaired postoperative sleep and risk of postoperative delirium development. Furthermore, sleep-based interventions in the ICU, like using eye masks, earplugs, and decreasing the number of overnight observations, reduces the incidence of postoperative delirium. One key issue in this field is that measuring sleep objectively and in detail is critical to understanding how sleep is affected in the postoperative period. As I mentioned previously, measuring the different stages of sleep is crucial to understanding how we think about sleep. One method that is commonly used is actigraphy, which is an objective measure, and it's used by inferring the movements that individuals make overnight and measuring heart rate. One way this is commonly implemented is through smartwatches, which many of us here might be using, and hopefully they're not capturing any REM sleep right now. But these are fairly unreliable, and the gold standard is polysomnography, which uses electrodes placed on the scalp to measure the different stages of sleep. When this has been used in the ICU, shows that there are specific sleep stages that have been impacted in the postoperative period, but these studies haven't concurrently measured postoperative delirium, so we don't know how these effects affect the development of postoperative delirium. So in summary, this framework trying to integrate neuroinflammation, sleep impairment, and postoperative delirium is hopefully yielding an idea about how postoperative delirium develops and the pathophysiology of it, and will provide incentive for clinicians in a collaborative way to increase postoperative sleep. Additionally, I hope I've identified research areas of interest for the future and how we can interpret previous research. Thanks for listening to my presentation tonight.
Yeah, James, thanks for a really interesting talk. I've literally just finished Why We Sleep by Matthew Walker, which I'm sure you would have read.
That was probably my inspiration for this topic.
Yeah. It's really interesting. So one of the comments in that book is that postoperative patients are woken multiple times a night for nursing observations.
Yeah.
How do you think we can get around that as surgeons to stop waking our patients up and subsequently disrupting their sleep?
Yeah, I think first recognizing the importance of sleep is important, and that every team member is aware that this is important. And then I think what we need to do is to basically triage patients based on how crucial these observations are. And in as much as we can to automate this process. So for instance, if you can have a SATS probe that's secure on their finger overnight and it doesn't fall off, you don't need to wake them up to put it back on. So just really emphasizing the fact that any way we can automate it or sort of prolong the duration between observations is quite crucial.
Okay, could you just turn off your presentation, James? Is that okay?
Yeah.
That's good. I'm interested. Narrative review has kind of gone out of fashion, really, with systematic reviews. What was your thinking behind choosing narrative review for this particular piece of work?
Yeah, so I definitely agree. It's as far as our evidence goes, it's a weaker way to analyze the literature. But I think in this instance, if a systematic review is much more difficult to do because research has looked at sleep and postoperative delirium, but has neglected neuroinflammation. And other studies have looked at neuroinflammation and postoperative delirium, but haven't really spoken about sleep. And so to integrate all three variables, there's really nothing that's been published that uses all of this information to come up with a theory of the pathophysiology in that way. So I think that's one of the strengths of a narrative review is you can integrate in lots of different fields together into one idea.
Yep. Okay, that's great. Any more questions? Okay, thank you for your presentation. That was really interesting. The next person on my list is Casey Fung. Casey, are you there?
Yep, I'm here.
I can see you. You want to get your presentation up?
Yep.
Okay, I can see that. So whenever you're ready, you can make a start.
Yeah. So hey everyone, my name's Casey. I'm a final year student at the University of Melbourne. Today I'm going to be presenting my project on is preoperative HbA1c a predictive biomarker of postoperative mortality and morbidity in patients following coronary artery bypass graft surgery. All right. A bit of background. So coronary artery bypass graft, also known as CAGS or CABG, is the most common cardiac surgery performed worldwide and also the recommended surgical treatment for severe coronary heart disease, which is also a leading cause of death globally. In Australia alone, annually there's about 17,000 cases across the country performed. And although it is life-saving, CABG is an invasive major procedure that has significant postoperative complications that go from early mortality to ongoing morbidity. Hence, it is really important to be able to identify patients at increased risk of developing postoperative complications and is crucial in guiding our postoperative management and also the long-term outcome of the patient. Recently, there's been blood-based biomarkers that have been investigated as simple and inexpensive tools to assist in risk stratification of our patients. So HbA1c is an indicator of average serum glucose over the past 3 months and is one such prognostic biomarker that has been shown to predict adverse outcomes following CAGs. HbA1c, we also know, is a marker of insulin resistance and is often elevated in patients undergoing CABG, irrespective of a diagnosis of diabetes mellitus, and is reflective of poor glucose control. There is extensive literature supporting the association of postoperative hyperglycemia with short and long-term morbidity. That's what we know so far. In addition, there are also several studies that have concluded that elevated baseline HbA1c reflecting poor preoperative glycemic control also predicts increased perioperative hyperglycemia. This then leads us to wonder whether there is utility of HbA1c in predicting those at increased risk of adverse clinical outcomes following coronary artery bypass graft. The current practice guidelines by the Society of Thoracic Surgeons regarding blood glucose management during adult cardiac surgery requires pre-op HbA1 screening only in diabetic patients and those at risk of postoperative hyperglycemia in order to guide postoperative management. Many guidelines have also provided recommendations on the preoperative HbA1c level for achieving better surgical outcomes in diabetic patients, but in the non-diabetic population, this is quite unclear. Hence, our aim in this project is to determine whether HbA1c is an independent pre-op predictor of postoperative 30-day mortality and major complications, and also to investigate the utility of HbA1c as a pre-op risk stratifying tool in all patients undergoing CAGs, irrespective of a diagnosis of diabetes. In our study design, we did a retrospective analysis of data obtained from the ANSCATS registry. We performed both a primary analysis and a secondary analysis. We had, out of 4,088 patients in the database, we excluded patients that did not have documented HbA1c level and only looked at patients who underwent only isolated CAGs. That was on pump, elective, and of these patients that we found, our study sample size went down to 1,393 patients. For our primary analysis, we also split up our patients into 2 groups based on HbA1c level, with 6.5% as the cutoff. And we treated HbA1c as a binary variable and ran statistical analysis on that and compared it with postoperative outcomes. And in our secondary analysis, HbA1c was considered a continuous variable and assessed with outcomes through multivariable logistic regression analysis. So as you can see, this is our study design and diagram. And this is a table demonstrating the baseline characteristics of our study population, stratified by the HbA1c level in our primary analysis. So this first table shows the results of our primary analysis. Our outcomes is listed on the left-hand side of the table. and 30-day mortality at the very bottom. And of the results, we saw significant association between elevated HbA1c with new renal failure, ICU readmission, and sternal wound infection. After running our secondary analysis, we found that the only correlation that remained significant was sternal wound infection. We found that increasing HbA1c level was associated with a decreased risk of atrial fibrillation. We also found that it was increasing HbA1c is associated with increased risk of prolonged ventilation, and there was no correlation with 30-day mortality. So what we can conclude is that HbA1c is a quick and inexpensive biomarker to predict patients at increased risk of prolonged ventilation, sternal wound infection, and atrial fibrillation following elective CAGs, independent of their diabetic status. This ultimately allows us to optimize patients prior to the surgery and resulting in better post-operative morbidity and reduced healthcare costs. Thank you.
Okay, that's great. Thank you for that. I enjoyed your presentation. Questions from the panel?
Yeah. Okay, Amy, go for it.
Sure. Casey, thanks for your presentation. I do a lot of work in diabetic high-risk foot clinics. So
okay.
We looked at HbA1c quite a lot for outcomes, and we found that BMI is also correlated with HbA1c, because by the time you get a HbA of 9%, you're pretty much a bit of a medical disaster.
Yeah.
Anyway, I didn't notice you tried to stratify for other risk factors. Did you look specifically at BMI? I might have missed the slide.
I did. Sorry, I ran out of time in the multivariable logistic regression analysis. So what we did do is we looked different factors and found that there were sort of factors that were correlated with outcomes, and that was inclusive of BMI, the age of the patient, as well as history of peripheral vascular disease, and also MI. And we put those factors into our logistic regression analysis and found that HbA1c still remained to be significant with sternal wound infection, prolonged ventilation, atrial fibrillation.
Yeah, Casey, thanks for the talk. Enjoyed it a lot. Did you actually look at HbA1c as a correlate in other surgery, just on the side? What does correlate with other type of morbidity from other surgeries?
So you mean like outside of cardiac surgery? Yeah. I didn't
Correct.
I didn't look in depth into it. When I was doing my literature review, I found that there were quite a few studies in the general surgery area that also saw correlation between high HbA1c and worsening outcomes. Not mortality, but definitely in terms of morbidity. I think sternal wound infection in general was going to be high risk, regardless of what operation you do, just because in that population of people, you tend to have issues with infection and wound healing. But I wasn't quite sure about specific other complications in those types of surgeries.
Okay, thank you. Any further questions? No, okay. Thank you very much for your presentation. I enjoyed that. Okay, and we will move along. Ian Barry. I can see a big eye on the screen. I assume that's you.
Yes.
You want to get your presentation up?
You can see it?
I can see that. Yep, you make a start whenever you want.
Brilliant, thank you very much. Good evening, everyone. My name is Ian Barry, one of the preset vascular registrars across in Western Australia. Today I'm going to be talking about the impact of closed incision negative pressure wound therapy on vascular wound infection and patient outcomes.
Would you be able to change it to presentation mode rather than speaker mode?
That better?
No.
No. Try sharing it again and see. The main slide was a bit small on the screen there.
How about now?
We've got the big eye.
Sorry about this.
Yeah, that's better. That looks
That's better.
That looks better. Yeah.
Is that okay? Sorry about that. Alrighty. So first of all, a bit of background on the topic. So surgical site infection is obviously a pretty common issue, no matter what surgical specialty you're involved in. One of the big issues with surgical site infection in the literature is standard definition. The definition that I'm going off here is the CDC definition, which specifically focuses on infection occurring after surgery in the part of the body where the surgery takes place. It can either be superficial, skin or subcutaneous tissues within 30 days, deep, occurring within 90 days, involving the muscle or fascial layers, and then organ space, meaning occurring yet again within 90 days, but involving this space deep to the fascial/muscular layers. So the burden of surgical site infection in Australia, well, approximately 2.5 million operations are performed annually with an overall incidence of approximately 3%. Within that cohort, risk factors for surgical site infection development are diabetics, cardiac disease, and obesity. And these are specifically strong correlative risk factors in vascular surgery, as a strong proportion of our patients have these risk factors. And in prospective studies, patients have been estimated to develop surgical site infection between 6 and 30% of surgeries. This increases length of stay, increases readmission, results in reoperation, as well as a high risk of graft failure and increased mortality. Now, what role does closed incision negative pressure wound therapy have to play? And this is just a brief slide on the mechanism of action, but yet again, it reduces lateral tension, increases apposition, and reduces seroma formation. And there has been studies specifically in general surgery and orthopedic surgery which have specifically looked at this and highlighted a significant benefit in reduction of surgical site infection. Although across both of these surgical specialties, there was a heterogeneity in regards to patient-centered outcomes, but also the definition of surgical site infection within these studies. In vascular surgery, there's been several randomized controlled trials, specifically looking at the role of closed incision negative pressure wound therapy. A Swedish study last year specifically looked at the outcome out to 90 days, but only specifically looked at the occurrence of surgical site infection, not at patient-centered outcomes. A further German study looked at the reduction yet again to 30 days with no secondary endpoints, while another German study specifically looks to 30 days, actually did have a focus on a patient-centered secondary outcome in regards to reoperation, but didn't look at readmission or impact on length of stay. In combining these studies, that again, a significant reduction in surgical site infection has been shown, but the definitions have been heterogeneous and the follow-up has also been quite varied. So in our analysis, we wanted to really assess whether or not closed incision negative pressure wound therapy utilization reduced surgical site infection, but also had an impact on patient-centered outcomes. We therefore performed an observational cohort study, specifically assessed the incidence of surgical site infection in a retrospective group, and then compared that to a prospective audit following a change in practice intervention with closed incision negative pressure wound therapy. The retrospective group was recorded over a 12-month period, while the prospective group was recorded over a 6-month period with 90-day follow-up for both groups. The primary aim or primary outcome was to assess the rate of groin wound surgical site infection within 90 days of surgery, while the secondary outcomes specifically examined reoperation, length of stay, unplanned readmission, as well as days alive and out of hospital at 90 days. This is just a few examples of the device that we utilized within this study, the Prevena device. And within the study, we had one sole applicator, which was myself, for all patients. And we didn't analyze it on an intention to treat basis, but not all patients within the prospective cohort received the closed incision negative pressure wound therapy. 89% did. A few cases performed out of hours whereby state coverage in regards to the vascular on-call roster did not receive closed incision negative pressure wound therapy. What this slide demonstrates from the baseline demographics is that there are relatively well-matched cohorts between the retrospective and prospective groups. No significant difference in age, sex, ethnicity, or emergency classification. Specifically looking at our results, so in the retrospective cohort, of which 76 groin incisions were performed, 16 or 21.1% developed a surgical site infection. while in the prospective group, this was reduced significantly down to 9.8% or 5 cases. Although this was not found to be statistically significant, when we looked at our patient-centered secondary outcomes, there was a significant reduction on unplanned readmission as well as reoperation due to surgical site infection. When we specifically looked at the impact on days alive and out of hospital at 90 days, this was significantly improved in those who had received the Prevena dressing, while total length of stay was also significantly less in those who received the Prevena device. In summary, yet again, between the two matched cohorts in this sort of quasi-experimental study design, it did appear to introduce a significant reduction in the surgical site infection occurrence, but also a significant impact on patient outcomes with reduction in readmission, reoperation, as well as improved days alive and out of hospital at 90 days, as I've mentioned. In conclusion, I feel like this study highlighted that a protocol of closed incision negative pressure wound therapy vascular surgery could be successfully introduced and is associated with a potential reduction in rate of SSI, unplanned readmission, and reoperation. Thank you very much.
That's great. If you could just stop sharing your screens. Thank you for that. I enjoyed that presentation. This is an area that all of us in vascular surgery are very interested in, and are starting to use it. One of the issues is if you look at the surgical site infection data worldwide and take the NESQIP data from the American databases, one of the confounders is that it may be just that a protocoled wound dressing rather than uncontrolled non-protocol dressing is what makes the difference rather than the suction. Were you able to control for that at all, or were all your retrospective patients subject to whatever the surgeon or nurse on the day felt like?
Yeah, to a degree, the biggest issue with matching between the two is more so the out of hours sort of practice, because that could be quite varied. But for our sort of daytime regular consultants, we didn't change any of our preoperative sort of regimen. We didn't change any of our screening processes. People received the same preoperative antibiotics. I think actually a lot of the benefit on closed incision negative pressure wound therapy isn't so much necessarily from the mode of action. I think it may actually be the fact that you're preserving sterility of a wound for an extended period of time rather than actually taking the dressing down. Certainly having a slightly more expensive device in situ probably deters consultants or registrars from disturbing the device too early.
So we could just put expensive dressings on. Yeah, gold-plated ones.
So in that case, a quick question. In that case, have you looked into just leaving the dressing alone? Any data looking just at that without the negative pressure?
So that's sort of actually my next plan with things going forwards. We're looking at doing a specific RCT comparing your stump dressing for major amputations in vascular surgery in comparison to a Prevena device to the stump, which obviously the stump dressings we leave for 5 days, the Prevena device we leave for 5 days, and doing a comparative arm between the two groups. I think that's something that may be more comparative, because sometimes with the infrainguinal or groin incisions, it can be difficult with this sort of absorbent adhesive to maintain that dry, intact wound just because of the area they're in. But certainly we're going to look at assessing that in that RCT we're hoping to set up.
Okay.
Ian, Marilyn Raj here. I've got a question. I'm not a vascular surgeon. So one of the things that I am often intrigued about is you mentioned a particular name, the Prevena dressing. I presume that that's a particular brand.
Yeah.
Are there other brands available, number one?
Yeah.
Why did you pick this particular one? And, you know, what's the, like, are there, like, sort of from a costings point of view, is this actually sort of practical in most hospitals, or are the costs exorbitant? Could you just quickly answer those? Yeah.
So first of all, yes, there's certainly other options from a closed incision negative pressure wound therapy point of view. The other option that we would mainly see utilised would be the PICO device. Now, what I did see from going through the literature of those papers I sort of mentioned before we looked at doing this change in practice protocol was that the majority of the research looking at this form of dressing was utilising the Prevena. So it was more sort of matching what had previously gone before in regards to dressing that had been utilised to make it more comparable with previous research. From a financial point of view, costing wise, I think the dressing on estimate just for the actual dressing is around $250. And then if you get the portable battery pack for the Prevena device, that's also $250. So in total, it is $500 approximately for each device. I'm not 100% sure on the Pico dressing price. I think it may even be slightly less, but not that much less. That obviously is a big increase in comparison, let's say if you're doing a MEP or an off-site dressing. But the reduction in readmission and reoperation, we're trying to potentially look, well, is that going to reduce overall costs?
Thank you.
Thank you.
Okay, thanks for those answers, and thanks for the presentation. I really enjoyed that.
Brilliant. Thank you very much.
Okay, moving along. The next presentation is from Abhishek Srinivas. Are you there?
Yes, I am. Just give me a second. I'll just share my screen now.
Okay.
Perfect. And how's that?
That's great. Okay, whenever you're ready.
Brilliant. So good evening, everyone. My name is Abhishek, and I'm a current BMSI honors student with the Department of Vascular Surgery at Monash Health. Prior to beginning, thank you very much for the College of Surgeons for having me. My presentation tonight shall highlight the accuracy of CT angiograms as an imaging modality for the investigation and diagnosis of type A aortic dissections. I would like to thank my mentors and supervisors, Mr. Ming Yi, Professor Smith, and Professor Lau, as well as the efforts of Dr. Tran in this project. So my presentation tonight will have three main parts. I'll begin with the rationale behind why this project was actually conducted, followed with the methods and results. And the final part of this presentation will just analyze the findings as well as highlight some of the areas we can move towards in the future with regards to type A dissections. So aortic dissections represent the most common emergency involving the aorta, with up to 80% of all cases occurring in the proximal part of the aorta, also known as a Stanford type A dissection. The current gold standard of treating this condition is open surgical repair, or OSR, but up to 20% of patients remain unsuitable for major OSR. Reasons for this are multifactorial. They could include the patient's age, the presence of other comorbidities, or simply just patient frailty. So we hypothesize that this proportion of patients can benefit from endovascular intervention, a technique that relies exclusively on preoperative CT angiography. Additionally, the benefits of endovascularly treating type A dissections include the avoiding of bypass as well as median stenotomies, both of which can confer better patient outcomes. So this brings us back to our question. Using surgical confirmation as a gold standard, what is the accuracy of CT angiograms? So to investigate this, we conducted a retrospective cohort study from January 2002 to November 2019, looking at all patients who presented with type A dissections at Monash Health. In total, we identified a total of 102 cases, with 22 patients having to be excluded. Reasons for exclusion were multifactorial, and it included patients passing away before operation, being transferred to other centers, or simply just being refused operation on the grounds of other comorbidities. As such, this left us with 80 patients who we then analyzed. So with regards to CT angiography interpretation, all preoperative findings were analyzed, with reviewers being blinded to the case's operative report, as well as findings from other imaging modalities, such as transthoracic echoes. These findings were then compared with operative reports written by surgical consultants and senior fellows obtained from Monash Health's Scan Medical Record System. We use the operative reports as the gold standard in calculating sensitivity, specificity, and accuracy values for 4 different parameters: the presence of pericardial collection, the presence of any pleural fluid, the site of dissection entry tear, and finally, if any supraaortic branch vessels were involved in the dissection. For further analysis, the causes of all false negative and false positive findings were reevaluated by a radiologist at a second unblinded reading. So updated to include all 80 cases, our results were as follows. We had a sensitivity, specificity, and accuracy of finding entry tears in the CT angiogram of all above 80%, with branches for branch vessel involvement being over 90%. The sensitivity of pericardial effusion detection by CT angiography was relatively low at 72%, which I shall examine further, with the specificity and accuracy values for pericardial effusions being high at above 85%, and similarly seen values being present for pleural effusions as well. So what does all of this mean? Our results were overall very comparable to the last study done of a similar nature, which was done in Tokyo in 2003, involving a total of 57 patients. It must be noted that this particular study didn't look at pleural effusions, and therefore was a change in methodology between ours and theirs. So the values in the second column of this table highlight the results found by the study in Tokyo, with the numbers in red and green highlighting the differences between our study and theirs. As is visible, most of the figures are within a range of 10%, apart from the sensitivity of pericardial effusion, where we had a slightly larger difference than expected when compared to the Tokyo study. So why did we have such a difference? So in total, we had 11 false negatives out of 80 cases for determining the presence of pericardial effusion on CT angiography. Rather than this being an issue with the innate nature of the imaging modality of CT angiography, we believe this to be a progressive nature of type A dissections itself, and the false negative findings being a direct result of the time lag between CT angiography and the actual operation. So the median timing for known operations involving false negative cases was upwards of 20 minutes, and it is entirely possible that the patients might have developed a hemoserous collection or a pericardial clot in this particular time frame. So in terms of our conclusions, to the author's knowledge, this is the first study of its type to be conducted within an Australian setting, but given the low incidence of type A dissections, about 30 per million per year, we do believe that further large-scale studies must be conducted to assess the reproducibility of these values. In terms of our current surgical practice, for present usage, we believe CT angiograms represent a highly accurate imaging modality in preoperative planning, and therefore is something that surgeons may confidently put their faith in prior to operating. In terms of future steps, the accuracy of CT angiograms represents an exciting multidisciplinary collaboration between three different fields, tying it back to tonight's theme. So between vascular surgery, cardiothoracic surgery, as well as interventional radiology, as we transition to minimally invasive surgery of the ascending aorta. And that brings me to the end of my presentation tonight. Thank you.
Thank you very much for your presentation. I enjoyed that. Have you got any questions from the panel? Let me start then. Obviously, rare condition, quite a wide timescale. How much improvement in CT technology occurred over that time from 2002 to 2019 in that centre?
So in terms of the actual modalities of CT angiography we use, there definitely has been an improvement in technology. Currently, the device we're using, the Toshiba CT scanner, is a gold standard, and I believe this has been in place since late 2007. So for more than 70% of our study, we have been using something that has been comparable to a world standard.
Okay. And you may have said, what in terms of the surgical procedures, what was the proportion of open and endoluminal procedures that were carried out on those patients?
Between a hybrid operation and just pure open operation?
Yeah.
So purely open techniques accounted for majority of the procedures. We had about 70% of all patients undertaking a pure open procedure as opposed to the frozen elephant trunk procedure.
Okay.
And that was just due to surgeon preference, what they were comfortable with.
Okay. On the basis of what you found then, is it likely that you're going to move more towards the hybrid endovascular procedures?
I believe that on the basis of what we found, there is a potential to move to an entirely endovascular procedure as well, rather than a hybrid between open and endovascular. Obviously, further research needs to be done, especially if the dissection continues to enter the aortic valve. But I do believe that the findings we've shown here show that there is enough ground for an entirely endovascular procedure to put trust in this imaging modality.
Okay, thank you. Any further questions? 2 seconds. If not, then thank you very much for your presentation. I enjoyed that. Okay. So the next presenter on the list would be Bijit Munshi. We'll move from type A dissections to type B dissections.
Hi, I'm just sharing my screen.
Okay.
You got it there?
Yep, that's great. Okay, we can see that. So whenever you're ready, you can make a start.
Okay, great. Thanks very much for the opportunity to present today. My name is Bijit. I'm a service registrar in vascular surgery, and I'm going to be presenting on the surgical decision-making in uncomplicated type B aortic dissection. This was earlier, this paper was published earlier in the year in the European Journal of Vascular and Endovascular Surgery in August. I work with a team of engineers and surgeons who are both locally and internationally based to collaborate in surgery, trying to find a solution in this difficult disease. Type aortic dissection is well recognised. A tear in the intimal layer occurs of the main artery of the body, and a false lumen forms. Our operative solution there is shown on the right, where you cover the entry tear, and then that causes thrombosis of the false lumen. Now, in complicated disease, there are clear indications for TIVA, which is the operative solution. These are listed here, including aortic rupture, pain, hypertension, and other morbidity that's associated with the disease. Currently, in uncomplicated disease, there is uncertainty. There's no consensus in the community. The INSTEAD trial showed that there were poorer outcomes for TIVA in the first 2 years, as indicated in these graphs, which are for all-cause mortality, aorta-specific mortality, and combined endpoint of progression and adverse events. The INSTEAD Excel trial showed that there are better outcomes for TIVA when follow-up period was extended to 5 years. And that's after a 2-year breakpoint in analysis, as shown by the vertical lines in those graphs. So this raised the question whether TIVA prevents late complication in this disease. And indeed, from registries, we know that maybe there is a 20 to 30% mortality after an event such as type B aortic dissection at 5 years. So these kinds of comments have been made that increasingly a more aggressive approach towards TIVA is being adopted by institutions, but the overtreatment may mean operative risk without later benefit. So the question that we're trying to answer through a survey that we've done, which gained expert opinions internationally, is what are the factors which are influencing decision-making regarding TIVA? So these are the opinions that we gained, 75 from Europe, United Kingdom, Australia, and New Zealand. And as you can see from this table, there's a good spread of geography throughout. Our survey design consisted of 3 categories. The first one was a question about preemptive TIVA, yes or no, in stable, uncomplicated cases. Preemptive TIVA is most often formed in the subacute phase after 2 weeks. Then we presented 5 case scenarios, which included currently recognized risk predictors. Within these case scenarios, the options were for best medical therapy alone or a combination with TIVA. These are the risk predictors that were incorporated into cases. And I'll show you an example of one of the cases that was actually used in the survey. There were some constants in there. So 73-year-old male, no past medical history, no connective tissue disease, but all of these risk factors were included in the case. So then we asked surgeons to rank those risk predictors, and that's where they come in their decision-making paradigm. Our findings were that with the question about preemptive TIVA, there's been uptake, but only about half of surgeons recommended at the moment. In Europe and Australia and New Zealand, those portions remained similar. An interesting finding was that we found that there was a predisposition towards TIVA. So if surgeons recommended preemptive TIVA, they were more likely in any case, 4 out of the 5 cases, to choose TIVA. And our third finding is quite unsurprising, diameter being an objective factor which can be identified on CT angiogram, as we've just heard about, being a critical factor in decision-making. In case 5, about 50% of surgeons chose TIVA based on large diameters, which does show that medical management is still favoured in this disease. In the ranking question, we found that the diameter-related risk factors were the ones which were ranked highest as well. So what does this paper add? We identified inconsistencies in practice between surgeons when they're presented with the same case. There's been only an uptake of preemptive TIVA by half of surgeons. The ultimate decision to intervene is driven by the surgeon's predisposition towards intervention, which is a subjective bias, but then also large diameters, which are objective but population-based thresholds rather than patient-specific thresholds. So what our engineering team is suggesting is that patient-specific risk prediction tools for a disease where you have unique morphologies and patient factors has to be designed. I'll leave you with this. This is the way that engineers are conceptualizing the same problem that we're looking at static images, 2D images for even now with all these modern technologies. Thanks very much.
Okay, thank you very much. You can just stop sharing the screen.
Yep.
That's great. Thank you for the presentation. I enjoyed that. Australia, New Zealand, and Europe. Why that? And were you expecting to get something different had you included the North American cohort of surgeons?
We did consider including North America. What we found was that the networks between United Kingdom, Europe, Australia and New Zealand are much stronger. In North America, practice is also different in the sense that you have a lot more private hospitals and networks, and a lot more interventionalists doing this procedure. So that could be anyone from interventional radiologists to cardiologists, as opposed to vascular surgery networks. So we had that synergy that already existed in terms of similar practice as well. And so that's why we gained responses from them.
Did anyone operate on the case with no risk factors mandating TIVA?
So there was, case 2 was the one which had no risk factors. And yes, there were people, I think there were 9 responses there, where people who basically said yes to every case were the ones who then said yes to that one.
Okay. Any other questions?
Bijit, thanks for that presentation. Marilyn Raj here. My question relates to the conclusions that you've come to with the level of evidence of how you sort of sought about obtaining the information for your study. One of the criticisms that's been raised in the past is that, you know, the use of expert opinion is sort of low-level evidence in the, you know, in the hierarchy of RCTs and random, etc. I guess my question relates to this. You've come to a conclusion that, you know, you want to develop a predictive type model for this particular rare condition, but you've based that on the level 5 evidence. Do you think that any particular, you know, other even retrospective study should be maybe done before, in order to gain, you know, any further information before you sort of try and come up with, you know, like a model? And could you sort of comment on, you know, whether you saw any deficiencies of using that expert opinion type model to generate your information?
Yeah, sure. I mean, I think in the broader context, the need for prediction tools in this disease is well recognized. I think that the paper that I have presented today is simply illustrative of a fact that vascular surgeons probably knew and suspected. What I think is important, and I mean, there was an editorial in the same edition of the European Journal of Vascular and Endovascular Surgery based around this paper, is that it does engender discussion which is useful for setting up patient registries, which ultimately would be the gold standard or a higher standard of evidence required. It is important, I think, sometimes in surgery, because we go day to day with our practice to sometimes question these things. And so the utility of a survey and using expert opinions which are spread geographically is to illustrate a point and really engender useful discussion, as opposed to coming to critical conclusions.
So would it be fairer to say then that the conclusion is that you need to now set up or collect data from prospective studies rather than that you would use the expert opinions to create a model? There's sort of an in-between step, isn't there?
Yeah, that's right. I mean, that was essentially because we are from a team of engineers. That is our aim eventually. But if going back to the paper, one of our main conclusions was that multi-center registries must be established, and there is one, the International Registry of Aortic Dissection, IRAD, which has done very, very good work over the last 20 years in that disease.
Thanks.
Thanks.
Okay, thanks very much for your presentation.
Thank you.
Enjoyed that. The next presenter is Catherine Zhu. Catherine, are you there?
Hello. Hello. Hi.
Hi. You got your presentation ready?
Share my screen with you, yes.
Got the...
Right.
There we go.
Right. Evening, everybody. My name is Catherine. I'm a colorectal fellow at Concord Hospital in Sydney, and my paper is titled "Preoperative Urinary Function Does Not Predict Postoperative Acute Urinary Retention in Males After Rectal Resection." So, as a bit of a background, we all know that urinary retention can be a relatively common complication following pelvic surgery, with a reported incidence of up to 24%. It's usually recognised early, and when treated, it's transient, but if left unrecognised, can be prolonged. Urinary retention itself, as well as its treatment, can lead to potential morbidity, including urinary tract infections, damage to the prostate or the urethra with repeated catheter insertion, patient discomfort, reduced mobility, and increased length of hospital stay and increased costs. And again, if left unrecognised, it can lead to long-term bladder and renal dysfunction. So what are the causes of urinary function, urinary retention? As with most things, it's often multifactorial. So there's often disease-related factors. In this paper's case, an example would be sort of a large, bulky, invasive rectal cancer. There's treatment-related factors, once again, in terms of rectal surgery, total mesorectal excision for rectal dissection, and often implicated cause of urinary retention is neurogenic, either traction or an actual nerve injury, as well as post-operative issues. And there are often patient-related factors, and that forms the basis of our study. So the hypothesis of the study was, does preoperative bladder outlet voiding dysfunction increase the risk of post-operative urinary retention in males undergoing rectal TME excision? And our thought was that if we managed to obtain a positive association, then perhaps it may stimulate further research into prophylaxis of urinary retention post-TME, and it may assist with individualising timing of trial avoid for patients undergoing TME. So the outcomes of the study primarily was the incidence of acute urinary retention, and secondary outcomes were the incidence of urinary tract infection and the length of hospital stay. So I performed a prospective multi-centre cohort study across 5 tertiary university hospitals and 4 associated private hospitals. All rectal resections were performed by or supervised by colorectal surgeons, subspecialty trained, to ensure the quality of TME dissection. The inclusion criteria were all males undergoing elective surgery for any pathology, undergoing either standard total mesoresection or mesorectal excision or partial mesorectal excision to below the peritoneal reflection. They could have any other additional abdominal colonic resection or modalities were included. Exclusion criteria were patients without an in situ prostate, inability to void per urethra, combined pelvic surgery, as that's known to increase the incidence of urinary complications, and emergency surgery. So preoperatively, patients were assessed with a focused medical history. Their preoperative urinary symptoms were assessed subjectively with International Prostate Symptom Score and objectively with a uroflowmetry as well as transabdominal ultrasound of the lower urinary tract, measuring specifically prostate volume, intravesical protrusion of the prostate, as well as post-void residual volume. Post-operatively, all patients were asked to have a trial avoid on or before post-operative day 5 unless there was some other clinical indicator to retain a catheter for longer. We standardised our definition of acute urinary retention so that there would be no confusion or confounding across centres. We also collected data on the incidence of post-operative urinary tract infections and complications, all of which were defined as within 30 days. We also collected information on data characteristics, post-operative details, as well as date of discharge. So we recruited 77 patients between June 2016 and January 2018, and of these 16 went into urinary retention, resulting in an incidence of 21%. Pre-operatively, there was no difference in baseline demographics, background, medical history, indication for surgery, or ASA score. We did not find any difference in preoperative urinary function between those who did and did not go into urinary retention, either subjectively or objectively. Intraoperatively, there were no statistically significant findings, although there was a trend towards a higher rate of urinary retention in those who underwent a pouch anal anastomosis. In terms of post-operative factors, again, there was no difference between the two groups, and importantly, there was no difference in the incidence of urinary tract infection or length of hospital stay between those who did and did not go into urinary retention. When we looked only at those patients who underwent TME for cancer, there was no difference in the use of neoadjuvant therapy or tumour TNM stage, or the fixity of the tumour within the pelvis. There was a slight, again, just a trend towards lower tumours being associated with urinary retention, but again, it didn't reach statistical significance. 5 patients developed a urinary tract infection post-operatively, resulting in an incidence of 6%. They tended to have a larger intravesical prostatic protrusion, which is a more sensitive measure of obstructive uropathy than prostate volume alone. They also tended to have a higher post-void residual, and they received more post-operative IV fluids, and they stayed for a longer duration in hospital. In conclusion, this is the first study to extensively investigate the effect of preoperative urinary function on postoperative retention after TME using objective parameters. We found no correlation between either symptoms or objective parameters, which may justify why prostatic medications lack efficacy in the prophylaxis or treatment of postoperative urinary tract infection. Didn't find any association to suggest a difference in the timing of trial avoid. Some minor associations with UTI were associated, but because the numbers are so small, we can't make any generalised conclusions. Thank you.
Okay, thank you very much. If you could stop sharing the screen. Have we got any questions from the panel?
Yeah, Catherine, thanks for your presentation. How has that changed your practice?
I think it has sort of not made me worry as much if somebody, comes in and has had a TERP before and is already on Flomaxtra and a whole bunch of urinary medications. It doesn't make me think that they need to have their catheter left in for longer than, another person who doesn't have any background urinary symptoms preoperatively.
Catherine, Marilyn Raj here. Why did you exclude women in your study?
Well, we were mainly looking at whether sort of obstructive uropathy, so like a benign prostate enlargement, would impact urinary retention. So that's mainly why we excluded all women.
And what was the mean age of your male cohort?
Let me go back to my screen. So the mean age was 61.
did you find any effect in the patients that had undergone radiotherapy for rectal cancer treatment?
No, we didn't. No, we didn't find any difference in neoadjuvant therapy use between the two groups, either as, radio as a group, or when you break it down between radiotherapy or chemotherapy.
Okay, thanks. Any further questions? Okay, thanks, Catherine.
Thanks very much.
Okay. And I think we now move on to Jenny. Jenny Pham, are you there? Oh.
Yep, I'm here.
That was quick and ready. That's great. Okay, start whenever you're ready.
Hi everyone. So my name is Jenny. I'm a final year medical student with the University of Melbourne, and my study is on the impact of rural surgical mentoring programs on students' attitudes towards surgical culture and rural training. So with the background, the rural surgical workforce has several challenges. According to RAC's 2018 census report, over the next 5 years, 1 in 5 fellows who work rurally plan to reduce their work hours, but less than 8% plan to increase their work hours. Additionally, another 80 fellows per year is needed until the year 2025 to service the community adequately. There's a geographic maldistribution of health professionals, with only 30% of Australian fellows reported working in rural or regional areas. And that includes those who work both in rural areas and in metro. And there is a declining interest in surgery, with an Australian study reporting only 22% of final year medical students being interested in surgery. And we know that decisions regarding specialty selection is happening during medical school. And so because mentoring programs seem to increase a student's perception of support and improve overall well-being, we wondered if we could use mentoring programs to change the perception of students in terms of surgical culture and rural training. So what we did was that we formed 8 one-on-one relationships between second year medical students and surgical consultants in Ballarat and Shepparton from March to October 2019. And during this year, the medical students complete their core rotations in general surgery, general medicine and emergency. Students were asked to complete surveys at the commencement and the end of the program, and the questions included those using a Likert scale as well as short answer questions. Our mentors were mostly from general surgery, orthopedics and urology. We were interested in students' demographics, their experience in medical school, their attitudes towards surgical culture, particularly work-life balance, sexual harassment and support, attitudes towards surgical training, rural training, and the students' aims for the program. So what were students' aims and were they achieved? So the mentoring program was quite successful in helping students understand surgical career pathways, as well as giving them an opportunity to network, giving them an insight into the lifestyle of surgical trainees and consultants, and helping them with working on challenges to get onto programs. It was less successful in academic performance or increasing academic performance and getting involved in surgical research. In terms of the impact on attitudes towards surgical culture, it was quite positive that at the end of the program, students felt that they would have a lot of support throughout training if they were to go into surgery. Not shown is that students remain concerned about work-life balance. And you can see in figure B that there was a difference between female and male respondents in terms of being concerned about sexual harassment, with females being more concerned. In terms of attitudes towards surgical pathways, students had a good understanding of the surgical career pathway. There was greater concern about building competitive portfolios for set entry, compared to the length of training. And there were mixed responses in terms of wanting to train rurally and accessing surgical training pathways in regional areas. And lastly, although students had a mixed view on their rural clinical placement, most of the students did not feel pressured to intern at tertiary hospitals at the end of the year. So in summary, mentoring programs contributed to a positive shift in attitudes towards surgical culture and rural training. Students improved their understanding of surgical career pathways, and although there were concerns about work-life balance, students gained a more encouraging view of the support that they would receive from colleagues. There was a difference in male and female attitudes towards sexual harassment, and that may contribute to gender disparity seen in surgery. Students became more positive to rural career pathways, feeling less pressured to intern at tertiary hospitals. Clearly, there were limitations on the study, having a small cohort, and were unable to identify students across both surveys. So with future directions, to expand the cohort of students and mentors, to include more female mentors and recruit younger mentors, and as well as to assess the mentor experience and the general impact on perhaps their working environment. And that's it, thank you.
Okay, thanks very much for that, Jenny. That's really interesting. Can I start just by asking you, what were the barriers? Because you had a cohort of 8 male mentors.
Yeah, so
what were the barriers to female mentors?
I couldn't really find many, so we targeted consultants and we couldn't find many female consultants that were responsive to our emails prior to the program running in March. And I think that has many factors to that. One being myself not familiar with all the consultants at each hospital. But yeah, generally creating it over summer also has its own challenges.
Okay. Other questions from the panel?
Jenny, Marilyn Raji, what was the reason that you actually undertook this study? What were you hoping to sort of show?
Well, so we know that less people, particularly as a rural clinical student myself, I think going rurally, there are social challenges, and I thought creating a mentoring program could help students feel welcomed in their rural places and therefore feel more, I guess, comfortable practicing rurally. And I think that's reflected in a lot of the research because, you know, there's quite high percentages of students who are interested in surgery because they've had good role models. And I just wanted to encourage people, I guess, perhaps through a mentoring program to see how well that worked.
How do you think we can get more women in mentorship programs?
I'm not sure. I think to definitely, you know, consciously recruit women, as well as, I think the issue with, I think there are many issues, particularly because there are fewer women in surgery, and I think they also get inundated with you know, opportunities to participate in mentoring programs. And I know that some feel like formal programs are not as effective as natural programs, but I don't know how to help with that.
If you can solve that problem, that would be the greatest research you can come up with.
Yeah.
That would be really wonderful. Thank you very much. Now, have you looked into what the mentorship equivalent is in the metropolitan area? And not just in Australia, around the world?
So there are studies in the US. I think the US has done this more so because their training style is a bit different and they're very big on mentoring. I'm not actually sure what the particular mentoring style is, whether it's one-on-one, whether it's there's different studies showing formal mentoring programs compared to informal programs. In Australia, though, there's very few, particularly in Victoria, I couldn't find any kind of studies showing mentoring with consultants and students on a one-on-one relationship and any research from that. And especially in rural areas, there seems to be no kind of program running. There are programs running between set trainees or pre-set trainees and consultants, but not so much medical students. Not quite sure why.
Okay. Okay, Jenny, thanks very much for your presentation. We really enjoyed that. Okay, next on the list is Bridget. Are you?
Yep. Is that
there we are.
Just working on sharing the screen again?
Okay.
So I'm Bridget. Hi. I'm currently an unaccredited registrar at Austin Health. Hopefully, Jenny, one day I can help you with your problem and be one of those female consultants you're having a hard time finding. And to start off with, just wanted to thank the committee and the audience for the opportunity to present at this year's state research paper presentations. So when I was initially looking into this year's topic of collaboration in surgery and trying to work out how I could develop a research project relevant to that theme, very quickly realised that in my day-to-day clinical life, multidisciplinary team meetings are both a really excellent example of collaborative teamwork and something that could potentially be also used as a surrogate marker of collaboration and teamwork, that we could also analyse with the goal of assessing whether we're making positive improvements over time or not. It's particularly relevant to hopefully a future career in surgery, as there's 10 domains that are considered core competencies by Royal Australasian College of Surgeons. One of those is collaboration and teamwork. Really, in my opinion, MDT actually includes elements from all 10 of these competencies, but in particular, it's an example of formalised collaboration and teamwork, not only between different surgical and medical specialties, but also allied health professionals and quite often the patient themselves in making complex decisions about their care. Definition of MDT is a deliberate, regular meeting involving a range of health professionals with expertise in diagnosis and management, with the purpose being facilitating best practice management for patients. So the next issue was, how was I going to investigate this? First searched the Medicare benefits scheme for item numbers that were relevant to specialist involvement in multidisciplinary team meetings, excluding those that were used by exclusively for non-surgical specialties such as GPs and psychiatrists, which interestingly, there were a lot for GPs and psychiatrists. I was then able to access claims data for these items numbers that's publicly available on the Medicare benefits scheme. And in order to ensure it was relevant to contemporary practice of the audience today, I decided to look at the most recent decade between 2009 and 2019. Regarding results, found 9 item numbers potentially used by surgical specialists to claim for their involvement in MDTs. And what was quite pleasing was there was a very clear trend of increasing use of these items over the last 10 years, both on a total count and per capita basis. And with the per capita increases reassuring us that that's representing a true increase in utilisation of the MDT, rather than just a proportional increase in relation to increasing population size. That trend was also evident on a state level analysis, with the exception of the Northern Territory that initially had a bit of a plateau and then started to pick up in the second half of the decade as well. The other point of interest when we looked at things on a state-based level was New South Wales actually stood out from the crowd in that it had not only a higher per capita rate of utilisation of the MDT item number data codes compared to any other state, but also the country. And they also had the greatest rate of increase. Sorry, I might have skipped a slide there. Anyway, I apologise. It was quite a succinct project, so I've come to the conclusion already. And my hope is that from that data, I can conclude that the increasing utilisation of the MBS codes for multidisciplinary team meetings across both the state and national level in Australia might evidence a cultural shift in practice in medicine with increasing collaboration and teamwork, which is one of the RAC's 10 core competencies. A couple of important considerations in analysing that data, though. There is a significant limitation to the MBS data in that it reflects the private system only, so it doesn't give us any evidence about the public hospital system, which is a large part of our healthcare system, that potentially being tertiary hospitals actually utilises MDTs more than the private hospitals. And with the data that we do have, it's also reliant on clinicians' awareness of the ability to claim that item number. So the true number might actually be higher. Future directions would be, how can we go about accessing the corresponding public data? I know there's certainly hospital statisticians who can help us access this kind of data for particular procedures performed in theatre, whether there's an equivalent person we can approach to try and gather the public data on a comparable state and national level for MDTs. Haven't had a chance to look into yet. Other potential analyses to look into this in more depth. It is possible to extract that data from the MBS statistics website also on a gender and age demographic basis, which could give us clues as to whether MDT is being used more in, say, older patients who might be becoming more complicated in their management with multiple comorbidities, or if there's any particular link to the patient's gender. And if I was able to achieve those things, then potentially in future looking into a comparison of the public and private systems to see if they're operating equivalently or if there's something for one system to learn from the other. And that's just back to the conclusion. Thank you.
Okay, thank you very much. Do you have any questions from the panel?
Bridget, Marilyn Raj here. That was a very interesting way to assess multidisciplinary approach to surgical care. So I commend you on that. The MDT, what sorts of deficiencies do you think may underlie your use of the ICD codes, etc., or the Medicare data for assessing the effectiveness of the MDT for promoting collaboration? What are the downsides?
Well, aside from having already mentioned, obviously it's only reflecting the private sphere. It's not reflecting the outcome of the MDT, it's just reflecting that it occurred. So whether each event that's counted in that count and that per capita rate had a positive impact on that patient's care, or whether nothing changed for that patient, I don't think it's going to be possible to gather that from MBS data. And I think often that can be a drawback with these big, I know Canada's got a lot of these big sort of population-wide, and Sweden's got a lot of population-wide databases. And while they can give you sort of nice big numbers to comment on, you've always got an awareness of, you're seeing the population numbers, but you're not seeing the individual patient stories as you might in, say, a clinical trial or a randomised control trial, or even a case series.
And that brings me to my next question, and that is that how do we know that an MDT is actually effective in terms of promoting patient management? Is there any data that you've come across that shows that, either within Australia or internationally? Because hospitals and organisations seem to promote the running of MDTs, funding's provided for them, but is there actually data out there that says that they work?
Look, to be honest, I couldn't quote you any particular study, name or catchphrase that does demonstrate that. It would all be on a sort of anecdotal personal experience basis that, my experience has been that the patients we discuss in MDT are the really tough ones where there's no clear, good answer for the patient. And, you've got a number of consultants who are all wanting each other's advice and second opinions to make sure that they're making a choice for, is this procedure the right thing for the patient, or should we be referring them on to, say, another specialty like medical oncology, radiation oncology, and then being able to go back to the patient and have that informed discussion with the patient to help them make what's going to be the best decision for them. But in terms of like a literature paper to quote, I'm sorry, no, I don't know of one. But maybe we can make one in future. We probably have to define some outcomes to measure it, and there might be challenging outcomes to define because you not only have objective outcomes like patient mortality, morbidity rates, but also I guess patient satisfaction and what their experience was.
Thank you.
Okay, thanks very much, Bridget.
Thank you.
Thank you. If we move along, the next presenter is Sharman Tantani. There we are. Maybe you want to pull your presentation up.
Yep.
That's great. Whenever you're ready.
Great. Thank you for this opportunity to present my research entitled High Resolution Impedance Manometry in Children with Esophageal Atresia. So as we're all aware, esophageal atresia is the most common congenital esophageal condition, affecting 1 in 2,600 newborns. And in this condition, the esophagus is not formed properly, and the newborns have an inability to swallow and require an operation during this period. But despite successful surgery, 85% go on to have esophageal dysmotility, even into adulthood. The most common type of esophageal atresia is associated with a distal tracheoesophageal fistula, as you can see here. We currently are not able to reliably predict the extent of esophageal dysmotility in esophageal atresia patients. But with the advent of high-resolution impedance manometry, we now have a way to accurately measure the esophageal wall compliance and contraction, and here we can see one of our patients undergoing such a study. She has an 8 French nasogastric catheter in place, and this has 32 pressure sensors 1 centimeter apart and 16 impedance channels 2 centimeters apart. And we can see in real time on the computer screen behind her the pressure trace as she takes swallows. During the study, we do 10 swallows of thin standardized bolus medium and 10 thick standardized bolus medium and 5 solid swallows. And as you can imagine, it's challenging to get a child to cooperate with this, and what they can take is dependent on their developmental stage as well. And so sometimes we do have to use the food that the parents bring in to be able to give us some meaningful data as well. So this is what a normal swallow looks like. We can see an upper trace, which is the upper esophageal sphincter, and a lower trace, which is the lower esophageal sphincter. Red on this diagram represents high pressure, while blue represents low pressure. And when a swallow is initiated, a relaxation is seen in the upper esophageal sphincter, and a pressure trace generated from top to bottom in a continual fashion, before a relaxation at the lower esophageal sphincter for the food to enter into the stomach. So the aim of my study is to characterize the esophageal motility patterns and determine the longitudinal changes in esophageal atresia patients. To put my study into context, this is occurring at the Royal Children's Hospital, a world-leading tertiary pediatric hospital. And we have the world's largest esophageal atresia database, started by Mr. Nate Myers since 1948. We have an expert team of pediatric surgeons who operate on 20 to 25 such patients in Victoria per year. And we have state-of-the-art equipment, which is the latest available commercially in the market. So my study adopts a prospective longitudinal cohort study design, and I undertake repeat assessments at 6-monthly intervals to assess for the longitudinal changes. When the patients attend, the parents complete the STACAC dysphagia questionnaire, which assesses the difficulty of swallowing different food consistencies from water through to stick. This will then allow us to match the symptoms with the findings on the studies. And so I've now conducted studies on 66 patients, of which 61% of them are male, and they have a median age of 14.8 months. And most commonly, we see distal tracheoesophageal fistula as expected. These patients have collectively undergone 115 high-resolution impedance manometry studies, and it takes me about an hour to conduct each study. All of them have had at least one study, 37 have had a second study, 11 have had a third, and 1 has had a fourth study. And this is what we have found on the initial study. 35% of the patients had a pattern of aperistosis, 33% had a distal contraction, and 9% had a pressurization pattern. This likely represents dysmotility. The remainder of the patients has a combination of different patterns. In terms of the longitudinal studies, in patients who had 2 analyzable studies, we found that 68% had maintained their motility findings. And in those with 3 analyzable studies, 67% maintained their motility findings. So in conclusion, this is currently the largest international study of high-resolution impedance manometry in esophageal atresia patients. We have found 2 predominant patterns, aperistosis and distal contraction. And we have also found that the motility patterns are maintained longitudinally. So the aim of my study is to then go on to risk stratify these patients by their motility patterns, so that it allows us to closely follow up those who are at high risk for further issues. So I'd like to acknowledge the people in the funding that have made this research possible, and I'll take any questions. Thank you.
Okay, thank you very much for that. Have we got any questions? I'm interested in, because you showed one of your subjects at the beginning, you said each study took an hour. How difficult is it in that very small, young group of children to actually get compliance with what is quite a long, drawn-out study?
Yeah.
I would have thought an hour was a pretty good time to get that sort of compliance with everything you're trying to do.
Yes, so there are certainly a lot of challenges, and we do find the age group of sort of between 2 to 4 years to be the most challenging. The little babies, we can wrap them and mom can give them breastfeed, that's all right. And the slightly older kids can follow quite well, but 2 to 4 age is usually the hardest group. And our nurse is very proficient in dealing with children in this particular procedure. So herself and myself are usually the ones in regular attendance, and occasionally we may have a consultant come in who knows the patient well as well. So we keep it to just these people to ensure that the child is not frightened by additional observers. And we do activities with them. Parents usually bring along some toys or some other distraction like music, depending on the child, or some books to read, and that helps along with the distraction. And at times we may need to mask what the actual thing they're swallowing is. So for example, if they don't like the taste of the standardized bolus medium, we might give them, one swallow of that, followed by a swallow of puree that they enjoy, and then we will then do, stop and change it up so that they are compliant with it. And certainly there are some times where we miss the number of swallows we require just because of the behavioral challenges, but we are able to analyze some of the swallows that are just saliva only if we have a sufficient duration of recording time.
Okay, thanks for that. Any other questions from the panel? A couple of seconds. If not, thank you very much for your presentation. I really enjoyed that.
Thanks.
Moving on to Jake Heinmarch. Jake, are you there?
Yep.
Am I ready to go? Okay, whenever you're ready.
Great. So thank you to the panel for letting me present my paper on evaluating the use of a low-fidelity inguinal canal model. And I'm a final year medical student at the University of Notre Dame. So a bit of an introduction. The anatomy of the inguinal canal is of paramount clinical significance due to the common occurrence of inguinal hernias, both direct and indirect. And it's often a source of great difficulty for medical students to understand. And in the past, low-fidelity anatomy models have been used widely to aid students' learning of such complex anatomical concepts. And advantages of these models include their ability to serve as memory aids, reduce cognitive load of learning a new concept, and also increase student enthusiasm and participation in anatomy. So we prepared an inexpensive 3D model to support student learning of the inguinal canal. And the model aimed to illustrate the borders, the orientation of the canal, and also the content of the inguinal canal. The aim of our study was to evaluate this low fidelity model and its ability to act as a learning aid amongst first year medical students. In regards to the methods, the model was prepared using readily available materials in under an hour at minimal financial cost, and students were randomised into intervention group and control group. Both groups were taught using a standard oral presentation of the inguinal canal and also prospected images, with the intervention group being taught with the addition of the inguinal canal model. At the end of the tutorial, both groups were given the same 7 multiple choice questions to assess student learning, and we also got some qualitative data on the model. So this is the model. It's actually constructed using a toothpaste box. So you can see the anterior aspect just showing the external oblique aponeurosis and the superficial ring with the spermatic cord coming out, and also the ilioinguinal nerve. And then the posterior aspect showing the deep inguinal ring of the transversalis fascia and the relationship of the inferior epigastric vessels to that deep inguinal ring. Also, we showed the lateral 1/3 of the aponeurosis lifted on the anterior aspect just to show the underlying internal oblique muscle. So these are the results of the quiz. So as you can see, on average, the intervention group that was taught with the model did perform better. And the quiz was just mainly aimed at assessing students' knowledge of the content of the inguinal canal, the borders, and how the deep and superficial ring relate to the inferior epigastric vessels. We also gained some qualitative data. So as you can see, most students either agree or strongly agree that the inguinal canal has the ability to improve their understanding of the borders, how structures enter and exit the canal, how the spermatic cord progresses through the canal, and their ability to visualize the inguinal canal as a 3D structure. We also got some free comments from the qualitative data. So I've broken them down into positive and negative comments. The main positive aspects of the canal were that it improved students' 3D visualization and also the simplicity of a 3D model rather than learning from a textbook. And some negative comments included that the model was inadequately labelled. So the model didn't have a left or right labelled, so some students had difficulty figuring out if it was the left or right inguinal canal. And also students expressed that they would have liked more time with the model. So the results of our study suggest that this inguinal canal and other low fidelity models do serve as effective learning aid for medical students. And it may be particularly useful in demonstrating the boundaries which form the inguinal canal, as well as the spatial relationships of the inguinal rings. And student feedback demonstrated that the model was well perceived by students. Positive themes include the model's ability to prove 3D visualization of the inguinal canal and also the model's simplicity. Areas of improvement, the model should have been labelled left or right to allow easier orientation, clearer labelling of the spermatic cord and the ilioinguinal nerve on the spermatic cord, and more hands-on time with the model. The limitations of the study include the relatively small sample size of 110 students and potential variability in pre-existing knowledge of the inguinal canal in first year medical students, and also the variability of tutor teaching styles. So in conclusion, a low fidelity model of the inguinal canal was developed to promote a deeper understanding of this anatomical region, and as it was often found to be an area that was quite challenging for medical students. And our model showed to be effective in addressing the objective at minimal cost. And the present study supports current literature in that low fidelity models are a useful adjunct to aid students' learning. That's the end. Any questions?
That was great. Thanks very much. If you could just stop sharing your screen. Questions from the panel? Anybody?
Yes, Marilyn Raj here. Thanks for a nice presentation. My question is, your model that you created was of the inguinal canal. Throughout your medical school training, were there any other particular anatomical spaces or concepts that you thought could also be better taught using a model type approach? Did you come across any?
Yeah, that's a really good question. I think the orbit of the eye and the extraocular eye muscles, I was thinking of doing, having a ping pong ball actually and showing how the extraorbital eye muscles actually move the eye. And also maybe the inner ear, showing the relationship of the ossicles and the various muscles and branches of the facial nerve and how they relate in a 3D way.
Thanks. And are there any commercial models that are available? Because you created this one, but what's out there?
Not that I'm aware of, no. And I'm also getting into 3D printing, so I'd like to, in the future, print models like this.
Thanks.
Okay, and Jake, just touching on something you mentioned there, the students that you involved, had they already had formal university teaching on the anatomy of the inguinal canal?
Yeah, so they had one formal lecture, and this was the first tutorial that they had on the inguinal canal. So they had previous knowledge.
And they'd all had the same.
Yeah,
the same teaching. Okay, great, thanks. Any other questions from the panel? No. If not, then thank you very much for your presentation. Okay, so that is the last of the presentations. So first of all, I'd like to thank all the presenters again for the hard work they put in for what was another very, very good and interesting set of presentations. I think they all, again, worked very well over this format. I'd like to thank Virginia and Catherine for the hard work they put in making this difficult format work really well for us. And to thank all my colleagues who put the time in, judges. And so once again, thank you everyone who's attended tonight for your attendance and for all the hard work. And that concludes the presentations for tonight.